Hello all, I'm Dr. Shweta Santhalia. You all know me. I'm sorry couldn't upload the video for a while, but I thought exam is nearing, so we should boost our preparation and gear up for the exam. So this is a recent SIP. Usually the SIPs are usually covered, most of the topic are covered in talks and guidelines, but this is a very recent SIP, and in UK everybody is talking about this. So I thought of recording this for you all so that you all can understand that there might be few questions from this simple. This is not a very big uh, paper to read, and it's simple to understand and simple to memorize. And we all know that full dilatation cesarean section and difficult delivery of the baby, impacted fetal head, these are few things we are always worried about when we do a cesarean section, that if we won't be able to deliver the fetal head, how we are going to manage that. If we encounter that situation, that is the nightmare for most of the obstetrician. And today's talk most likely will help you overcoming your fear, and you would be able to apply some of this knowledge in your practical experience as well in your clinical practice, which will help you um, being a better clinician. So yeah, let's start. So it has been published in June 2023. So if we talk about cesarean birth, we all know that cesarean birth is increasing. Everywhere it is increasing. In UK, over 1/4 of women, that means 25% of the women, have cesarean birth, out of which more than 1 in 20 happened when the cervix is fully dilated, which is second stage cesarean section. So yes, whenever the labor is prolonged, when the baby head become lodged deep in maternal pelvis, it become a challenge to deliver the baby while cesarean section. Now, what is impacted fetal head? Basically, during the cesarean section, difficulty in delivering the fetal head may happen, and this emergency is impacted fetal head. Like shoulder dystocia is a clinical diagnosis when you see that head has come out and turtleneck sign and shoulder is not coming out and restitution has not happened. These all tell you that the shoulder dystocia has happened. There's no fixed definition. If you need extra assistance for the delivery of shoulder, you declare it as a shoulder dystocia. The same way, when you need extra intervention to deliver the baby head, when the difficulty is there, you can't deliver it by your usual method of introducing your hand and flexing and removing. Then, when you need additional maneuver or you need to cholesis to relax, to give you space, then it is an impacted fetal head. So the definition is that when during a cesarean birth, obstetrician is unable to deliver the fetal head with their usual delivering hand, an additional maneuver and or tocolysis are required to disimpact and deliver the head. It called impacted fetal head. What could be the causes of impacted fetal head? Because not all impacted fetal head are in second stage. Most of the time we think that second stage cesarean are the most difficult ones because the baby will be very deep. The baby will be deep in the pelvis, the station will be low, as well as uh, it gives more difficulty because of the friable lower segment. But they say that the impacted fetal head, that means the difficulty of delivering the fetal head, happens only in 1/3 cases of full dilatation cervical cesarean section. So full dilatation cesarean section, 2/3 of the time you will see that there will be no impacted fetal head. So where else the impacted fetal head happens? It can happen in first stage. They say that more than 50% of the cases of impacted fetal head is actually in first stage, means before full dilatation. So it could be at 4, 5, 6, 7, any any dilatation of cervix, you can encounter an impacted head. So why it happens? It happens if the fetal malposition is there. If the head malposition is there, the bigger diameter enter the pelvis and it can't pass through the pelvis, then it will be there in that position for a long time, and then it become impacted. It can also be seen in cases of prolonged labor, like when we do oxytocin augmentation and for the prolonged time, like 12 hours, 24 hours oxytocin augmentation, and if you see the feature of obstructed labor, like blood-stained urine and vulval swelling, these are some feature of obstructed labor. If there is a lot of caput and molding on fetal head, this is a sign of obstructed labor and CPD. If the fetal station is very low, like at the spine or below, then it becomes difficult to deliver and it becomes more impacted. So these are few causes for impacted fetal head. So the impacted fetal head as well as its complication are being encountered more frequently by health professional nowadays, because if you push too hard for vaginal delivery and things are not going as expected, labor is getting prolonged, sometimes the patient refuses to accept the delivery by cesarean section, and you have to uh, wait for them to either the baby head, fetal head rotate, or they might progress or they might not progress. But sometimes if you feel that the labor is not progressing, you think that the cesarean section is the best option, and the patient say that no, she wants to wait. In that cases, the clinical dilemma comes that now the best suitable option patient is not choosing. So it's always a risk for the mother and the baby. The latest UK study says that impacted fetal head may complicate as many as 1 in 10 unplanned cesarean birth. So unplanned means most of the emergency cesarean birth. So in 1 in 10 means 10% of unplanned cesarean birth. So total 1.5% of all birth overall can be impacted fetal head. If we talk about uh, how much it affects the baby, how much the baby can get injured or can have mortality, then 2 in 100 babies. So out of 1.5% of all birth or 10% of unplanned cesarean section, 2% of the baby will either die or will be seriously injured because of the impacted fetal head and difficult delivery of the fetal head. So if we talk about cesarean section, we know that 1 in 4. So different countries have different incidences, but 25 to 30% incidence of cesarean section, and out of which 5% are full dilatation cesarean section. In full dilatation cesarean section, 1/3 will have impacted fetal head. But more than 50% of the cases of impacted fetal head happens in the first stage of labor. So these are very important fact which you should remember, which is also important for your clinical counseling, even to talking to the patient, even for your understanding and your clinical practice. So what could happen if impacted fetal head will happen? Definitely there could be complication for the mother as well as complication for the baby. So for baby, definitely we know that there could be trauma, there could be fractures, hemorrhages, uh, there could be hypoxic injury to the brain, there could be even death. So these are the risks to the baby. For mother, what can happen? For mother, because you're trying to disimpact the head and deliver it, because of the stretched edematous lower uterine segment, there's increased risk of extension. If there will be extension, there will be more bleeding. So more bleeding, more hemorrhage, more PPH. If there will be extension, it can go to ureter as well. So bladder and ureteric injury. It can go to bladder as well down. So bladder and ureteric injury. Now, a very interesting fact about what I came across reading the SIP is that there is a potential long-term consequences in future pregnancy of a spontaneous preterm birth. Though it is understandable because the lower segment is so thin and there is a chance of injury to the cervix and all that things, but still, nobody would think that an impacted fetal head can lead to preterm birth in next pregnancy. So keep this in mind, keep this fact in mind, because all other you must be knowing, but this is a new fact. Why anything is important? Whenever there is a medical legal thing associated with that, when there is expense associated with that, everybody cares, right? The organization care, the doctors care, everybody care, the patient care. So nearly 10% of most expensive maternity claim are because of this, because of impacted fetal head, because of the injury to the baby, because of the bad outcomes. So it is twice as common as shoulder dystocia. So impacted fetal head is more common than shoulder dystocia, twice as common as shoulder dystocia for medical legal uh, consequences. So how you can prevent it? How you can prevent impacted fetal head? Practically, the reason could be malposition, the reason could be big caput molding. So the early decision of delivery, when to stop, when to tell the patient that this is not safe to continue now for taking the labor forward, giving you oxytocin drip, waiting is not a good idea, would be the best prevention. To avoid the impaction of the head would be best prevention. But yes, if it happens, if you are anticipating, if your mind is saying that it might be an impacted fetal head because of the risk factors, then you can always prepare yourself. You can always, when you take her to theater, you can do the vaginal disimpaction, which is called push method, to elevate the fetal head. The other thing is fetal pillow. We all are aware that fetal pillow could be used from down below to elevate the fetal head. But recently in UK, the studies have come across which are saying that high quality data is required for fetal pillow, and it is not very cost effective. The cost of fetal pillow and the outcome, what was uh, earlier told, is not very convincing. The studies are biased. It's not high quality study. So now this fetal pillow is going in disfavor in UK practice. It has been recent come up that we have to do further study to authorize it again to be used. So in cesarean section, whenever you do a cesarean section, for any routine cesarean section or if impacted fetal head, what you have to do is you have to do abdominocephalic disimpaction. So basically you have to introduce your hand and then you have to lift the fetal head, flex it and remove it, right? So the most important thing is how to introduce your hand. Should you introduce your hand in the middle, on the sides? From where you should introduce? What's the right thing to do? So as such, the literature doesn't say what's the right way of doing it. But in this SIP, they have mentioned that transverse diameter is the wider above the impacted fetal head. So if you go anterolaterally, it will be less traumatic. So anterolaterally introduce your hand and then sweep your hand on the fetal head and come in the middle. So this will help uh, avoiding the introduction space, which will you will get more in the lateral, and then you will come slowly gently in the middle to avoid pressure on the uterine angle while baby head delivery. So this is what they have mentioned. The other thing, important thing, is to flex the fetal head. If you don't flex the fetal head, the bigger diameter will be there and it will not come out and all the injuries will be more. So flexion is the key always for the fetal head delivery. So flexion is very, very important for disimpaction. How you have to, once you have introduced your hand and your hand is in the middle, your hand should be parallel to the patient abdomen, parallel to the women body. And the pull should be applied towards the women head. This is very important. You don't apply the pull towards the ceiling. You have to apply the pull towards the women head. So towards the women head, parallel to the women body, when you apply the pull, you will not injure the lower segment and you will be able to flex and disimpact the fetal head, and that will be the most smooth and gentle delivery. Now, uh, if you're doing that, obviously you might have noticed most of the time when you do a difficult delivery, you go more towards the maternal thorax, right? You take more space there because your hand has to go in the pelvis and you have to pull it towards the mother head. So you have to stand more towards the maternal thorax. And they say that if you are using dominant hand, you can see towards mother head and use your dominant hand. And if you're using your non-dominant hand to disimpact, then you can see towards the maternal feet and disimpact. So both way it can be done, but most important thing is if you're using your dominant hand, then better you move more towards maternal upper body and you see towards maternal head, and that will give you your hand the space to disimpact. You should never flex your wrist, which is very important. This is a very important point for impacted fetal head, that your hand should be straight. You should never flex the wrist. So hand should be straight, parallel to the women body. Apply the pull towards the women head, disimpact the head, flex the head, and then deliver it gently through the uterine incision. Sometimes this doesn't work. You try your best abdominocalcic disimpaction, but sometimes it doesn't work whatever hard you try. It's a very much distorted head, malpositioned head, rotated, and with all your maneuvers, also you are not able to disimpact. So what should we do then? Then we should talk to our team. We should take a pause. We should talk to our team that this is what I'm encountering. Anesthetist, can you please give me some relaxation? This is what we ask, right? So in uterine relaxation, they say that when we enter our hand below the fetal head, then the uterus contract. Any stimulation, the uterus will contract, fetal spine will be splinting, and that will hinder the disimpaction of the fetal head in delivery. So when you introduce your hand, then take a pause. Give the uterus time to accommodate your hand to relax. And then you should try to deliver the baby. So that pause is very, very important. And if you feel that you can't disimpact and you need more relaxation, you can always ask the anesthetist to give some tocolysis. Now, the other point of tocolysis is that it can lead to PPH, atonic PPH, which we are worried about. That's why we never want to give a tocolysis. But the baby delivery is first and foremost thing. Uh, After baby delivery, whatever complication of impacted fetal head will be there that we can manage. But if we will not deliver the baby in a right way, in the right time, then baby get compromised. So you can ask for tocolysis, which is short half-life, which is mentioned as sublingual GTN. So sublingual glyceryl trinitrate is what you're going to tell your anesthetist to give so that you get a fraction of second, for some fraction of time, the uterus will be relaxed and you'll be able to deliver the baby. It help you in maneuverability basically. If you have more space and more relaxation, your hand can maneuver the baby's head easily. Now, you tried your usual method, it didn't work. You gave the tocolysis or not given the tocolysis according to your protocol in the hospital. Then what is your next method? Then you ask for help, isn't it? You ask somebody, so please help. So that you call your assistant, either the experienced obstetrician or experienced midwife who will come and help you. So this is the vaginal disimpaction or push technique. So what the assistant will do, they will use their cup hand and finger to elevate the fetal head, which is called as Pringle hand technique. It shouldn't be with the fingertip, but the palmar surface of all four finger and thumb to cradle the fetal head and then flex and elevate. So the vaginal end, your assistant is helping you, and at the abdominal end, you are trying to deliver. So your hand will meet, and the vaginal end person will give you the fetal head, and then you can deliver. It helps you in flexion. Basically, they flex, and it helps you in further flexion and disimpaction. So that is called vaginal disimpaction or push technique, which is widely practiced in UK. This is the only method which is widely practiced in UK. So push technique is still the most famous one here. So if you see the vaginal disimpaction, the assistant hand is like the cup, the palmar surface of the finger and the thumb, and flexing and giving to the surgeon, the fetal head for further flexion. Surgeon hand can't reach further down. There is no space. So once the assistant will push it up, it will be easy for the surgeon to further flex and deliver the baby. So how it will look at vaginal end, your full hand has to go in. It's not only two finger. Your full hand to go in, cup the fetal head, flex it, lift it, give it to the surgeon, and he will further flex it and then deliver. Now the other method is reverse breech extraction. And in UK, in the SIP, they have mentioned that 50%, approximately 50% of the UK trainees are aware about reverse breech extraction, and some have done it in their practice. So it's around 50%. So it's not that everybody is aware of this technique. That means still the training of reverse breech extraction and uh, familiarity should be improved. So if vaginal disimpaction, which is the ubiquitous practice in UK, is not working, or somebody wants to do reverse breech extraction, they say that it is more common in the low resource setting where the obstetric labor is very common and they keep delivering by this method. So what the operator should do in reverse breech extraction? The name itself says reverse breech. That means the breech will come first. Ideally, the head should come first in a cephalic presentation, but here the breech is coming first in a cephalic presentation. That's why it is called reverse breech extraction. So what you have to do is you have to do a continuous traction to one or both feet of the baby, and you have to pull it towards the women feet so that you flex the waist of the baby and deliver the leg and breech. So if you see, you will introduce your hand. Now, because the head is so much deeply in the pelvis, like especially with the failed instrumental delivery, caput, molding, failed instrumental delivery, you know that head is quite low and it is going to be a difficult cesarean section and difficult delivery, right? So in that situation where you are already anticipating it, what you can do is introduce your hand from the incision, go up, hold 1 or 2 feet, whichever you can grab here, they can hold 1 feet, then pull it. Once you pull this feet, this will automatically come down. So 2 feet, and then you will remove 2 feet, right? So hold 1 feet, try to pull 1 or 2 feet, and then gradually 2 feet you will remove. Once you have removed 2 feet, then you have to do like you do the vaginal, like you do the abdominal or vaginal breech delivery. Keep the back anterior, very important. So if you see now, the surgeon has gone towards maternal head, right? As I told you, for any impacted fetal head, you should stand more towards the upper body of women, not towards the incision. So the operator has gone up, and then the breech has come out, and now the baby head is down, so we have to straighten the baby, right? So the breech has come out, bilateral flexion, then you have straighten it. So you kept the back anterior, then you are removing one hand, then you are removing other hand, and now once you have done that, you will disimpact the head and deliver it. So this is called reverse breech extraction. The other method is Patwardhan method, Patwardhan maneuver, which is mentioned in the SIP, and I'm very proud of it that it has been invented in India. So Patwardhan maneuver is the modification of reverse breech extraction only, where the arms are delivered first. So this is mainly for the babies who are in occipito anterior position. Like if you can't, this is occipito posterior position, right? So you can easily find the feet. But if it is occipito anterior position, it's difficult to find the feet because feet are on the back side. So in occipito anterior, they talk about Patwardhan maneuver, where the feet are difficult to access. So this is the Patwardhan maneuver, where you deliver both the hands. And then once you have delivered the hand, then you slowly, gently, your assistant will give fundal pressure and you will gently deliver the buttocks. And once the buttocks are delivered, then you will lift. And then it will be very easy to lift out the fetal head. The same like reverse breech extraction. Once the body is out, there will be no suction down then. It will all get released because body is already out. So the head will easily come out. Or if it is still difficult, you can use the Martius Melivet technique, where you put 2 fingers on the malar prominence and one on the nape of the neck and occiput and flex the head to deliver. So this is a Patwardhan method, and some modification of Patwardhan method is also there. So still it is not a very established technique and no clear steps has been given, but this is the basic principle of Patwardhan method. So they may ask you in the exam if occipital anterior, uh, which method you can use, or they may ask you reverse breech extraction or the vaginal disimpaction, how many fingers or how it is done. So having the idea, and this is also a practical point which will help, which will always be useful to discuss so that it helps in our clinical practice as well. Now, sometimes you don't know, you might have not done reverse breech extraction or Patwardhan method and you are not aware of how to do that. Or sometimes if you want to do reverse breech extraction, you need more space. You can't reach the feet. You have introduced your hand, but you can't reach the feet. You need more space. This incision is not enough. So what you will do, you will extend your incision. That will give you more access, right? Like we do episiotomy in shoulder dystocia to give more access to maneuver. The same way here, the operator can do inverted T or J shape incision to help in reverse breech extraction or Patwardhan maneuver. Because you want to pull the baby uh, the uterus always grab the baby, right? So pulling the baby won't be so easy, and the membrane is ruptured, the liquor is drained. There is not enough uh, flexibility for the baby to smoothly come out. So uterus try to grab the baby, and sometimes the space is not enough. So uh, that's why we talk about the role of tocolysis. In the same way, if we get more access, if we give the incision a little bigger, so inverted T or J-shaped incision, it can improve the access. So in conclusion, they say that there is not possible to derive the firm conclusion that which technique is superior over other. Whatever the clinician is aware of and whatever they know how to do it, they can choose that. But these are all the possible options. And as I told you, in UK, still the vaginal disimpaction is the most famous, and the fetal pillow is now going out of favor. So that's not the good choice now. Earlier, we used to put fetal pillow if the baby's head is at the level of spine or below. But now we are refraining from that practice because they have questioned it, and they told that further studies and evidence are needed to prove that it is cost effective, and it's making a difference in the outcome for the baby or the mother. So uh, that's why that is not your option. But the other could be tocolysis, uh, which will be sublingual glycerol trinitrite. There could be vaginal disimpaction. There could be reverse breech extraction. There could be Patwardhan method. So these are the options you can choose. So if we talk about the algorithm of impacted fetal head, first of all, diagnose impacted fetal head. Anticipation for diagnosis, anticipation is always a good thing because you're mentally prepared. So whenever you have a difficult labor, malposition, advanced cervical dilatation, fail instrument, you always think about difficult delivery. So explain the possibility to women, to birth partner, to the team, to the anesthetist, to the midwife. Everybody should be aware that you are anticipating a difficult baby delivery here. Then you prepare. How you prepare? You inform the senior obstetrician, you alert the team, you allocate the midwife obstetrician to wear the sterile glove and be ready for vaginal disimpaction. You tell the anesthetist, I might ask you for glycerol trinitrite, sublingual, and then you keep the table height at the lower level, because when the height is lower level, your hand will be straight and it will not flex, and it gives you more better control over it. So always table height should be lower. Uh, and vaginal disimpaction can be used. Once you have diagnosed the impacted fetal head, means the difficult delivery, and you need some maneuver to deliver the fetal head now, your standard maneuver has failed, you have to declare the emergency that it's impacted fetal head. Like we tell, it's shoulder dystocia. So the same way you have to tell that it's impacted fetal head. We need help. So you declare the emergency, you inform the partner, so the anesthetist can inform also, or the midwife can talk to the birth partner as well as patient about what's going on. Then you call for help, senior person will come, arrive there, then you will pause. Why you will pause? Because you want the uterus to relax and you want your mind to formulate a plan that what next you're going to do. So pause, and then you can consider tocolysis. You will try abdominocephalic disimpaction. You will consider changing hand. If you can't do it with right hand, you will try doing it with left hand. Sometimes the angle difference, sometimes the way the both hand work. As I told you, when you're using your dominant hand, you have to see towards mother head, and if you're using your non-dominant hand, you have to see towards mother feet. Your head should see towards mother feet. So these all different way of standing, your body language, like you will go more towards upper body of women, the head will be, the table will be low. These all ergonomics will help you in disimpacting and delivering safely, gently, without damaging much to the lower segment, as well as avoiding extension, avoiding fetal injuries. So consider changing hand is a possibility if you are comfortable with that. Then you will inform the consultant obstetrician. If you can't do it or you're finding it very difficult, then you can take help from another obstetrician. Again, if you have reached to this stage, you should inform the neonatologist that baby might be little compromised. They should be ready for resuscitation. You should inform the team that we might be having PPH after this, so be ready for that mentally. So you are communicating amongst your team, which is like non-technical skill, which is very much required in an emergency. It's not only technical skill, but right communication at the right time to the team makes a lot of difference in the outcome. So in any emergency, working in synchrony, working as a team make a difference. So you have informed your team, you are ready, you are anticipating things, you are making your mind prepared, body prepared, as well as your team prepared. Then what to do? What will be the other obstetrician, more experienced obstetrician, or you are already tried and you couldn't do it, so yes, somebody else can do with their fresh mind. So what they will do, again, vaginal disimpaction can be tried with the semi-lithotomy position for the women, so that will give more space for the disimpaction at the vaginal end. You can change the approach if there is no progress. Either you can do vaginal impaction or you can increase the incision and go for reverse breech extraction. So both way it is fine, whatever way. If this is not working, go for this. If this is not working, go for this. So it's interchangeable. If it doesn't work, then you have to either repeat one of this. If you have tried vaginal, it didn't work, you tried reverse breech, it didn't work, then one of them you can again try, or you can consider Patwardhan maneuver. So this is what the algorithm, this is what like shoulder dystocia, the algorithm for impacted fetal head. So I believe that this is important for you to go through that what will be the next step. Like abdominocephalic disimpaction, you have tried, it didn't work, what next? Consider changing hand. They might ask you this in exam. Consider changing hand, then what next? Inform the consultant. What next? Vaginal disimpaction or reverse breech extraction? What next? Patwardhan. When you will consider tocolysis before the disimpaction. So these are all the important points which can be asked in the exam as well. So that's it for today. Thank you so much for listening this video. And the registration for July 2024 exam has been started. So if anybody is interested in joining the course for July, you can contact us. So all the best for your exam and all the best for July candidate to start their preparation. Thank you.